Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Azra AI. We would like to remind you that the chat feature is available, so feel free to send in your questions for the panel throughout the discussion. Our speakers would love to hear from you. And with that, I will turn it over to our moderator, Brooke Blackmore.
Good afternoon, everyone, and thank you so much for joining today's session on harnessing AI in oncology. My name is Brooke Blackmore, and I get the privilege of moderating today's session. I lead clinical operations here at Azra AI and serve as the vice president. Azra AI is a health tech startup company that harnesses and uses AI and automation to accelerate the identification and treatment of cancer patients. We're live in over 200 hospitals today. And over the course of my career, have had the privilege and opportunity to work with clinical and operational experts to ensure that we operationalize and maximize clinical workflows in hospitals and healthcare systems to ensure that patients' care is elevated, all while ensuring that healthcare systems can maintain and maximize the revenue as well. And so enough about me. I am joined today with an esteemed panel, Dr. Flora and Jamie today. And so I wanted to take just a couple minutes to give them the opportunity to introduce themselves to everyone. And so thank you, Dr. Flora, so much for joining us today. Could you please share a little bit about yourself and the St. Elizabeth healthcare system?
Yep. Thanks for having me, guys. So I'm Doug Flora. I'm a treating medical oncologist here just outside of Cincinnati at St. Elizabeth Healthcare. We are a large hospital system with about 6 cancer program centers. And I'm the clinical chief with a dyad partner across the hall who manages our operations. And she's managed to build a pretty slick place in terms of operations and using a few of your tools, similar tools. So excited to hear the discussions today and glad to be here. My side gig is I'm the editor-in-chief of a new journal, AI and Precision Oncology. So I have a particular interest in AI and using machine learning and tools to make our care more human.
Wonderful. Thank you so much, Dr. Flora. And we are thrilled to have you on today's session. And Jamie, I'll turn it over to you to share a little bit about yourself and the Inspira Healthcare Network.
Great. Thank you so much, Brooke. My name is Jamie Denigris, and my background is nursing. And I've been working with oncology patients in various capacities for probably almost the last 20 years. I have my master's. I'm a certified oncology nurse, and currently I work at Inspira Health in South Jersey as the director of support services. I oversee our navigation program, our social work services, our incidental and low dose screening program, our high risk, and just various other supportive services within our hospital. We are located in South Jersey. We have over 250 locations for our Inspira services, so we are a very large network and also a growing cancer center. I've been here for over 5 years, and in the past I've worked in Philadelphia as a director on an inpatient oncology unit. So I really have gotten to see both sides of the oncology patient experience, and it's really helped me to shape my overall goals of care for our patients and see the full spectrum of the oncology patient journey. So I'm very excited to be here and share my experiences with you. Thank you.
Thanks, Jamie. It sounds like you've done a little bit of everything as well as you, Dr. Flora. So we are excited to lean in and learn from you today. And so for the audience, again, we are so glad that you are here. We hope that you walk away understanding a couple of things specifically around, do you have cancer patients that are being missed? Is their treatment being delayed? What does your cancer registry operations look like? And are their workflows manual? How are your navigators, your oncology navigators, managing their care of patients to ensure that no patient is left behind or no patient falls through the cracks? And so today we are excited to give you some information to take home to learn how we accelerate cancer identification and treatment with AI. We're automating these key oncology workflows on behalf of the patient and their experience transforming your navigation program, hopefully from a cost center to a profit center, enabling greater health equity throughout AI and automation, which I know is a buzzword today, and we are excited to dive into together. And then how do you start using AI to maximize your oncology service line? So I will add and just echo, we welcome any questions that you have. Please enter them in the chat feature, and we will ask our audience. If for some reason we don't have time to answer your question, we will certainly follow up with you individually to make sure you get the information that you wanted. So without further ado, let's dive into some of the content that we have that we are excited to share with you. Dr. Flora, I really want to start with you first and discuss how did hospitals and healthcare systems get to this point? You know, you mentioned you are recognized as the AI doctor. You speak about AI. You are the editor-in-chief of the journal AI and Precision Oncology. You know, how did you become so interested in AI?
I'm a nerd, so that's the first place. I like tech, and I read a lot about tech. And I got turned on to this stuff in my leadership role, not as the doctor, but as the executive director here, when we started to tackle things with staffing shortages, with difficulties managing just this tsunami of medical data being thrown at medical oncologists and our teams, and started to look for solution sets for that. And part of that led to a lot of study and a lot of reading, which is what nerdy oncologists do when we find problems. And I found the tech solutions to be very compelling, and sort of threw myself into that and found myself here today. I don't know if I would say the AI doctor. There are billions of people who probably know more. What I do know is how these things can affect us in the clinic. And I may not be doing the mathematical algorithms, but I'm the one using the tools that we're hoping to bring to the market from industry sorts like yourself and from the academics that are publishing on this today.
Yeah, absolutely. Absolutely. And I've not ever heard the term tsunami of data, but that is exactly what it is. So good analogy there. And, you know, it is imperative and apparent that AI and automation is needed for successful hospital operations, clinical and financial outcomes. What circumstances or trends have made AI so critical to the well-being, to not only the hospitals and the staff, but to the patients?
Well, I think it's probably two things that have come very recently at us. One is the availability of the technology. It's become affordable. It's become accessible. The transformers that came brought technologies that moved so quickly, and the machine learning and deep learning has helped us. But the problem that we're trying to solve has just mounted really since COVID. We don't have staff. We have 400 open nursing positions just in this hospital that's sitting behind me. And they're good jobs and they're well-paying jobs. And we're making plenty of nurses, but they're going on to be nurse practitioners or advanced practice providers, or they're going to work in research or industry. And we can't keep up. So those staffing things have led me and led our institution to look for creative solutions, recognizing that we may never have more nurse navigators or may never have enough nurses. And that's where tech solutions can streamline our care.
Yeah, exactly. And I know that I hear often across the industry that, you know, when you get the positions filled, they're full of these administrative tasks or things that they didn't know they were going to have to do. And in a role like oncology or a nurse navigator, you know, you're signed up to help remove barriers to care, and you want to spend time with patients and the providers that are, you know, coming up with the care plan for those patients. And so that's where I also have seen AI really have tremendous value in removing some of those administrative barriers as well. So Jamie, would love to take a moment and transition over to you. You had the opportunity to actually be what I would consider an early adopter of an AI solution and technology. So you've had the opportunity to see firsthand how it elevated your oncology operations. And so can you talk a little bit about Inspira and how they use AI in the workflows today?
Absolutely. Yeah. I mean, we use it, and we started it back in 2019. So definitely in the beginning of the trend. We identify cancers in real time now, and we ensure the navigators can support our patients even prior to patients making treatment decisions. You know, this helps ensure we address barriers prior. It increases the patient experience and satisfaction, and also increases our hospital retention rates. And being able to identify these patients and connect them right away is key. I mean, timeliness, I think, as you know, working in oncology or anything, timeliness really is key for these patients to get them in and treated and diagnosed. In addition, we use AI to operationalize our cancer registry teams. We use the AZRA platform to ID patients in real time. They populate to metric and ensure that the team can, you know, really work as efficiently as possible. And lastly, we use the AZRA AI platform to identify incidental findings. And now newly, we manage our lung screening program. So it's been really, really great to leverage our partnership with AZRA to really elevate our program as a whole, and we continue to elevate it. You know, we're not done. There's a whole, you know, future still. So, you know, it's an exciting work.
Definitely, definitely. And there are so many navigation programs that I would call reactive, right? Let's support patients at first appointment. Let's make sure that the providers are giving a referral when patients surface barriers. And what we've been able to leverage with you through our partnership also, you know, that I think is really impactful on the patient's experiences. Let's alert the care coordination staff as soon as a patient is identified so their barriers can start to be removed right away. And you start to support that patient before they turn to Google or before they've even made a treatment decision, so that they have that support really early on. So that's been really incredible to watch with your implementation as well. And I know nurse to nurse, and there are a lot of different types of clinicians on the line today. So in the spirit of keeping the patients, you know, really at the center of our conversation, I wanted to really early on in today's session ask you, outside of, you know, clinical operations and financial gain, what is your favorite patient impact or an example of a patient impact that the AI technology has allowed you to leverage?
So there really are so many. I said I could take the whole hour sharing, but I will share two quick stories that really, I think, encompass the work that we're doing. At the very, very beginning of the AZRA journey, I remember, I think it was within the first week or so, we had a patient, we were doing the incidental program, you know, came in after a work injury to the ER, left with, you know, cardiac issues and all of that. But he had a CT scan because everybody gets a CT scan in the ED. And, you know, he never got follow-up for it. And he had a large nodule. The PCP wasn't really aware because he didn't know he was in the ER, and the patients don't follow up after the ER. And we were able to capture that. And within a week, we called the patient, let him know, got him connected to our thoracic surgeon, and he had a lung cancer. And he was resected by our, you know, one of our physicians here at Inspira. And then most recently, we had a patient through our low dose screening program who was in his mid 80s, living alone, no family, no transport. He had a provider ordered the test and recommended to get follow-up PET scan, but he's in his 80s, no patient advocate. We were able to capture that patient. And within 2 days, we got him in to see our thoracic surgeon. We had him a PET scan, we had him biopsies, the whole gamut. And he was also diagnosed with lung cancer. And, you know, he, to this day, about 5 months later, he's still one of our most dear patients, and he still will keep in touch with our navigator, and we still get him transport to wherever he needs to go, whether it's for oncology or not. So the connections that we make for these patients and the trust that we're building with this is really, you can't measure that success.
So patients, you know, I think everywhere come into the ED not expecting to find cancer. And unfortunately, it's there. And a lot of these cancers don't have side effects or symptoms, you know, when you're coming in to the ED. And so lung cancer specifically, I think, is the one that most people gravitate to first when they're building out a program. You know, you got to catch it early if you want to be a survivor. And so those are really great examples. And I think the reason why we're all here and wanting to learn about how we can use AI to operationalize workflows and get patients connected in real time. Dr. Flora, I'm sure you would agree that it is not an isolated issue in New Jersey, that these patients, unfortunately, are likely falling through the cracks across the United States.
Yeah, we're at ground zero here. I sit and I'm looking in Kentucky, where it's the #1 state in the country for lung cancer diagnoses, #1 state still for lung cancer deaths, but we've thrown ourselves pretty wholly into that. I think we might have either the first or second place now for number of screens done in the country. We're looking at about 36,000 patients scanned. And to speak to Jamie's point, about every 29 unique scans we do, we find a lung cancer here. And through these technologies and with this aggressive screening approach, it's been good for a couple of reasons. One is obviously in the white coat, I love that we're saving these lives because now you have about 140% greater chance of being found with stage 1 disease. And we've cut the number of stage 4s in our screen patients by over 90%. The business people on the call or in the room will recognize that's a high ROI for the system because surgical patients who are saved are also patients that have good margins for operating suites and for COOs and CFOs. So it's one of those places where administration and the clinical team like myself, we all agree this is our big aim is let's save some lives and let's do it efficiently and in a way that might keep the lights on.
Yeah, absolutely. I think we hear more and more of opportunities in the radiology space to surface incidental findings to ensure follow-up. But Jamie, you mentioned something that is obviously near and dear to me and interesting, that you're also leveraging AI in the pathology space with your cancer registry teams. And so I know for anyone in the audience today that is familiar with the cancer registry operations, that generally, unfortunately, they are extremely manual, require review of all pathology reports to surface the positives in which healthcare systems are required to report on. And just like Dr. Flora mentioned, the shortage of nurses, we may even have a larger problem with the shortage of certified tumor registrars, honestly. And so where nurses are going to be NPs or go to industry, the registrars are going to contracted services, and hospital systems are having to spend more and more money to keep that data up to speed and accurate. So would love, Jamie, to hear a little bit about not only how you're leveraging AI in the radiology space in incidental findings, but what the pathology impact has been as well.
Yeah, I mean, no, it enables us to really know our volumes in real time, which we never had that before. We get to see the referral patterns, the team productivity. Historically, we do look to the registry, like you said, for that data, and the NCDB for data, but it's typically months behind, or they're waiting for the treatment series to end. But with our data from ASRA now, I can, in a matter of minutes, find out how many new lung cancer patients we have, new breast cancer patients we have. It supports our accreditations. It supports our growing program. Our cancer program is still growing, at our Mulligan Hill location. So having these volumes at the tip of our fingers is very vital. And the best combination of AI is to really accelerate that patient care. Again, with our navigation program, we can take those positive patients, know them right away, remove the barriers, ensure the patients remain compliant to their treatment plan. And it really has helped tremendously ensure our data is accurate. And we're no longer required to enter, that manual, data like we were before.
Yeah, wonderful. We actually have a couple of questions that have come in through the audience. So I'll take a pause and maybe Dr. Flora, direct this one to you. So the question is, I'm curious how folks in benefits at large employers can better assess vendors that claim to use AI, machine learning, and large language models. It seems like there is a lot of smoke and mirrors. What comments would you have towards that question?
I think that's it for me. And that's actually a great question, Dylan. That's why I started this journal, because I'm the clinician and the purchaser in my system. And we would be driving these things as the medical doctors, and the executive director is responsible for helping make those decisions about where resources are allocated. So there is a ton of enthusiasm. My entire Twitter feed, or X now, is just populated by this stuff. And as you might imagine, I'm approached by quite a few vendors because of my enthusiasm for these technologies. I think the way that we're approaching it is we're setting up a group of subject matter experts in our IT division, our chief medical information officer, people who are interested in these things, to vet the technologies just as carefully as we would something, a robot or a machine that we would use for surgery. I think it's going to be important upon us to vet these things, because everybody's slapping AI labels on everything, to make sure that the people who are offering solutions have a proven track record. I've been stung with one that comes to mind that we bought. And it was a $220,000 program a couple of years back when we were starting our precision medicine program, only to find out later they really had like 4 employees and they could not perform the heavy lift that we needed them to do. And it was a very disappointing relationship. So if I'm looking at products like Azra, I'm calling Jamie and I'm going to schedule an hour with her user group. And if I have an operations person or a prior auth person or my chief registrar, our manager over our tumor registry, I want them to talk to their colleagues and find out that whatever tool it is, whether it's Azra or one of the others out there, that they have been able to deliver the things that they've promised, because there is a lot of noise and we want to find signal.
So in a follow-up question that came through to that, Dr. Flora, is there a use case, in your opinion, to identify clinical trial options leveraging AI?
Yeah, I think we'll look back at this era as a paradigm shift when this stuff started to happen. Obviously, to screen thousands of patients for millions of trials, it's daunting. And with first-in-time trials and these basket trials, where we're now matching a specific FGFR2 mutation to a cholangiocarcinoma patient in the Midwest, this is where big data can really solve some problems. And there are a number of companies that are out there that are scraping the data, both on the screening side from pathology reports, but also from unstructured data in physicians' notes to try and identify and screen those patients for our clinical trial institutes across the country. And as we're trying to get these things into community hospitals, which is where the majority of patients are being seen, these tools can do those things without having to require addition of staff and very limited resources.
Definitely. And thank you for that follow-up, Dr. Flora. And I know, Jamie, we talked a little bit about how your program's using AI. So thank you for that. Would love to hear from you, Dr. Flora, on that. How does St. Elizabeth today use AI and automation in oncology workflows?
There are a bunch of places. I mean, we've embraced AI and capture of our lung cancer screening program and our solitary pulmonary nodules, our incidental and actually are moving into what happens if you find an unexpected cardiac calcification, and building a program to take those folks who are incidentally found to have worrisome findings on a low dose CT for lung cancer screening and moving them into the cardiology spectrum. So we're excited about that. And we probably couldn't do that without a tech solution. It's just too many data points for our 3 nurse navigators to keep up with. And they're remarkable. They're great at it. But this is where the machine can really extend them. For us, we've been using them for things like managing our genotypic stuff, our pharmacogenomics program, trying to identify people that need DPD screening or pharmacogenomic assays, and putting those into a usable interface for patient decisions and clinical decision making. I know on the lab side, we're digitalizing all of our slides, and pretty soon you're going to be seeing augmented reads of mammography with one of the mammography reading programs augmenting our mammographers. Hopefully soon we'll do the same with low dose CT. Not replacing doctors, but augmenting them with the ability to discern patterns that are really too subtle for the human eye still.
I think you just made a really good point. Not replacing doctors or necessarily replacing staff or humans, but making their lives easier, more efficient, optimizing them to the top of their licensure, and then seeing things that are outside the scope of what humans can do is really, really a good point that we always try to drive home as well. So thank you for that. And I know recently you had discussed about including, investments upstream in areas like community outreach or high risk patient management, and screening assets. Could you share a little bit about how you think AI and automation can help with the high risk patient management and screenings?
Yeah, and it's always been a difficulty. And I sit both sides of the fence because I'm an administrator now part-time, having to make really tough decisions about where resources are allocated, and trying to put that into context. If we buy this software program, can it generate enough safety gains or quality gains or margins or whatever to cover the costs of more employees who are going to hug patients? And so that's always the thing is this product worth 3 social workers? And a lot of the new tech solutions have been, and they've made it possible to get 4 or 5 or 6 social workers because they've been able to find efficiencies that we couldn't discern on our own. From a doctor standpoint, I've tried to make an ROI argument to my senior leadership in finance, saying that, as I said, not only are we saving patients, we're providing highly good quality care, highly efficient care, and there is a financial downstream ROI for those captures. For everybody that Jamie described that's identified to have something, you can put it into a business plan now and show published data suggesting that if you do a low dose CT, there's nearly a $300 possible profit while you're saving that person's life that might pay for that social worker or that nurse navigator or a genetic counselor that doesn't have an easily demonstrable ROI. And we're in a not-for-profit system with razor-thin margins. So every dollar that we spend, we want to try and stretch as much as we can to try and help the greatest number of patients.
Yeah, definitely. And we had a good question come through around, how do hospitals ensure, especially you, Dr. Flora, in doing patient care still, and Jamie, your navigators, how do you make sure that AI and automation doesn't result in, a loss of that personal touch and connection with the patient?
Yeah, well, that's a big push, and my argument's the contrary. And this isn't just me. These are leaders in the field like Eric Topol in his book, Deep Medicine, which always sits behind me and kind of started my mind thinking about this stuff. If we can save doctors 3 or 4 hours a day of documentation, or nurses on the floors where these visits are automatically captured in those rote mechanical things that we waste our days doing for payers or for documentation go away, I have 4 more hours a day to be present for my patient and visit the depths of their caves with them, which is why I went into oncology. So for me, I think it's the opposite. I think these tech tools may actually end up fixing the doctor-patient relationship and delivering me back into the room instead of into the computer screen.
That's a great analogy. And I saw Jamie scribble down the title of the book. So book club coming next.
That's Deep Medicine, Jamie, 2019, Eric Topol.
There you go. Any comments, Jamie, from you? I know he's speaking from a physician perspective, but just care coordination and the navigators and how they use AI to make sure their touch remains personal with the patient.
Yeah, and I definitely agree. I think the way this technology is moving, it is bringing the clinicians back to the bedside, back to those patients. I always say when we went to the electronic medical record, you see these inpatient nurses, they're away from the patients because of technology, always charting, making sure they have all their, I's dotted and all of that. But this really is, taking so much of the work away from all that manual, all that administrative stuff. Clinicians and nurses, they want to be with the patients and help them. They don't want to be behind a computer screen, just searching through records and stuff. So it really, the way that this is heading is really, I agree, it's saving time and bringing us all back to the patients where we belong.
And I think, going back to oncology navigation, it was seen as almost as a requirement in a lot of hospitals. They felt like they had to have it, or even the accreditations that they had were requiring navigation. And so how do you use AI or even your automated workflows to shift from this cost center over to a profit center type of mentality, while obviously keeping the patient at the center of what you do?
I mean, it's really, we help decrease, the out migration by supporting our ordering physicians and providers, but also being able to provide that service to the patient, in a way that we do also helps us stand out. It does. I mean, we're calling these patients, ahead of time before sometimes they've even, like you said, make the treatment decisions and all of that. And again, it's we're using this software to really elevate our patient experience, focus on timeliness of care, and elevating even our partnerships with our doctors, our providers and stuff, knowing that we have these tools that are reminders to them as well, which is I know a lot of our partners, they love us. We have so many community doctors. We have a very large network that aren't all attached to Inspira. So we're able to really support them as well, and just make the appointments. We coordinate anything to ensure they have the proper workup and diagnosis. So it really is. And I will say, navigation, you have to prove why it's worth it, and it's hard because, we're not getting paid for it, but it really is that downstream. I mean, you can't make that up. I mean, there's so much downstream from having these navigators and utilizing the software with that. It's a win-win.
And I know Dr. Flora alluded to, even the examples that you said in the radiology space, and then leveraging your nurse navigators, getting them practicing at the top of their licensure to be the first one after they know about their diagnosis to do outreach and start supporting the patient. I always envision this patient getting diagnosed at home more and more nowadays. And where would I go? I would go to Google. and how would my life or my treatment journey be transformed if the very next phone call was my navigator, was the support system that was going to be connected to my hospital and provider that I was going to get my care from. Mm-hmm. And so again, I think it's a win-win of, yes, you can show this data points and these downstream revenue, that's generated from these stories, but also while making sure your patients are kept at the center of what you do. So that's really great insight. Dr. Flora, you mentioned, this came in from the audience, you mentioned those 4 extra hours. And so do you think the 4 extra hours saved will lead to more face-to-face care with the same number of patients? Or do you feel like you're going to be pushed to see even more patients now that you have more time?
It's a smart question. I'm an eternal optimist. So I think the majority of oncologists wish we could spend more time with our patients. And I have the luxury of doing so in my building since I set my own schedules. And we don't have any pressures here to see more. In fact, most of the time I'm sending emails to my docs asking, are you okay? Because I see the RVUs and they're nuts. I would say, Sarah, it should be inherent upon us that we want to spend more time. I think it will solve access issues if we find those 4 hours. So the people who cannot get in off the street for 16 days to see an oncologist in small rural towns, I believe that will be potentially life-changing for that sort of access. And I'm embarrassed to say I'm not confident that every doctor is not going to pack their schedule just as tightly. And shame on us. That's not why we went into oncologists, and that's not unique to oncology, but we have a fairly perverse set of incentives right now in medicine, and it is a volume-based thing, and we're pushing against that. And we've got a lot of salaried people here at St. Elizabeth. Most of the places that you would wish you would emulate are now salaried, like Mayo Clinic, and the better hospitals that you are aware of are conscious of the fact that not all doctors should be incented to rush. So I'm going to remain optimistic and think that this system may sort itself out because the number of patients is growing. We have to be smarter about getting access for them. But I'm hoping that the people who go into medicine, and particularly in oncology, are softer than the average, and that we chose this because we want to save people.
That's right. That's right. It's a really good question and a good point, so wanted to quickly shift gears just a little bit. We, or hopefully the audience has seen, if you have not, please look this up. The Centers for Medicare and Medicaid Services recently announced a really exciting proposal around the reimbursement for hospitals and oncology navigation services. So would love to maybe, Jamie, start with you on what are your thoughts about this and how are you feeling about that?
So, any profit obviously is great for the hospital. It's what we need to survive, to keep going day by day. But I do, when caring for an oncology patient and also as an oncology nurse, in my heart and my soul, it's, getting the patient to care is what's most important. And the navigators that's who gets them to care. That's who they do the hand holding, they support them through everything. So yes, I think the business side of me and the work is very deserving of reimbursement. It is probably one of the most crucial jobs next to the physician, and the nurse practitioners there. So I'm all for it, but personally, I wouldn't want to truthfully see a patient billed for that service because I think that downstream revenue is enough. And, I also wouldn't want, an insurance company to deny that care, and then what do? You have to be fair and all of that. So it will be interesting to see how that rolls out, honestly, to see what the stipulations around it are.
Dr. Flora, are you familiar with that announcement and any initial thoughts?
Sure. We were excited. I shared it widely on my LinkedIn. I think it's a major step forward. It's a big step in the moonshot to recognize that it's not going to be providers alone that are caring for these patients. There are going to be maybe 13,000 oncologists and 22 million survivors in 2030. Great problem to have, but they have to see someone. And so these things that will reimburse for good quality care that's delivered, that keeps people out of hospitals, away from emergency departments, reduces readmissions, all the things that we all hear about all the time when we talk about government payers, can be enhanced by a sticky nurse navigator who's part of the family. And so we've invested pretty heavily in it. We just got 2 more approved. And I'm pleased to say our senior leadership understands the value to our system. I hope my nurse navigators do, because they are close friends of mine, and they are the thing that we're building our entire system around. And to speak to Jamie's point, we're up 35% in volumes, and patients have recognized it, and people are staying in the system or seeking our system because that personalized touch. So again, I'm conscious of the fact that some of our audience here wants to do the right thing, but also has to keep the lights on. And I have the luxury that I have really good people around me managing the operations, so I could say things like this. But I think that you can do both at the same time, and we don't have to choose good business versus good medicine. Really high quality medicine is better for both.
I'm optimistic personally because I believe that it will at least get more navigators there. So Jamie, you make a good point. There's certainly kinks to be worked out, but I think for hospital systems or healthcare systems that aren't quite as enthused about getting that support arm, as Dr. Flores at St. Elizabeth may be, some of these other ones that, need to really invest in that program may have more of an incentive to do so. And then I think the downstream impact to the patient will be seen, but definitely something to keep an eye on, and that definitely caught our attention as well. Mm-hmm. So wanted to transition. So we've talked a lot about AI and how we use AI and the buzzword. Another buzzword that we're hearing frequently is health equity. And so Dr. Flora, what is health equity to you, and what does it mean to you in your practice?
I mean, it's on us. It's critical. We've got to do this. So health equity for me is making sure that your zip code doesn't determine more than your genetic code, that you are not receiving substandard care and screening, prevention, treatment because of your race or socioeconomic status or your neighborhood or your access or language barriers. So to speak to some of the stuff that Jamie and I have talked about for screening. So you got a guy like me, lives next door in a nice neighborhood, and I have easy access to my provider, and I've got tons of access to screening, and I have a job that lets me have PTO to get my colonoscopy, and I've got a car, and I've got an education in health literacy. I'm likely to have better outcomes than somebody who lives just 2 miles away, who works for an hourly wage, who's a single mother of 3, who can't get PTO to get her colonoscopy. She doesn't have a car. She has to take the bus. She has no chance for health literacy. And it's a totally unfair system. And we're really working, I think, globally, but also locally to try and address that for some of our populations where the screening numbers aren't nearly as brisk. And they should be. Young men, young Black men under 50 aren't getting colonoscopies anywhere near the rate that they should, even though their risks are higher. Young Black women get a different version of breast cancer and need a different level of intensity of screening and often don't get it. So we've got to work together as a community to do that. AI is one of those tools that has promise, but it's also got its own hangups and its own problems in terms of program bias. So we're going to have to police that as well.
That's exactly right. And so how do you see potentially AI helping solve for that? I agree with you. There's definitely, almost ensuring from the vendor's perspective or whoever you choose to partner with to make sure that data bias isn't there. And that's why those conversations that you spoke to at the beginning of the webinar are so critical. But how can AI help make sure that, equal access is there for all?
I think it's a great equalizer for providers. And so maybe if you have fewer providers per patient and they have higher treatment panels, some of the decision analysis, some of the best practice advisories and warnings that the technology can pop up can equalize a beleaguered provider who doesn't maybe have the same level of experience or doesn't have the same level of access to information. So that with decision support, over your right shoulder with a digital personal assistant, reminding you that this patient needs a whole body MRI for their Li-Fraumeni syndrome, that might elevate the care in some of these small communities and rural populations where the doctors aren't up on that, whereas they might be in Boston or Manhattan. So I think that's some promise for this stuff for sure.
Yeah. And Jamie, you did something really interesting at Inspira where let's definitely surface every nodule. We don't want to look at gender. We don't want to look at age. We absolutely don't want to look at insurance. We want to give everyone equal access to surfacing in the care queue, and instead chose to prioritize the workflows in the way and the order in which those patients were surfaced based on the criticality of the nodule. Mm-hmm. Any thoughts around that from a health equity perspective that you would say?
Yeah, I mean, we are, we're a community-based, hospital, and we are surrounded by, Philadelphia. We've got a lot of big names around us, but, I always like to say we're getting care close to home. We're the big name here in the community. So we have a lot to prove to our community. And we are as you know, we have the grants, like we offer free screenings for mammograms. I mean, we did, I think, over 1,500 free mammos up in our Cumberland area alone. And it shouldn't matter, and we're very lucky to have a system that, the one patient that I spoke to about earlier, the little 80-year-old man with lung cancer, we didn't accept his insurance, but you know what? We figured it out, and we got, we hit those, we took those barriers, and we got past them. So I agree, we have to be the leaders in just caring for patients, no matter what, regardless. And AI does help. I mean, you have reminders, it's like, hey, your screening is coming up. I mean, it gives you that access and that data right at your hands to know, okay, these patients need their mammogram this year. You can utilize it in so many different ways for reminders and supporting the patients.
And I know, yes, hospital systems are operating on these razor thin margins. And so we did have a question that came through the chat around, how long does it take for you to see your growth impact and your EBITDA increase from this? And I'll just say, from us and the clients that we've had the opportunity and privilege to work with, it's been really impactful to be able, even the first day, 2 days, week, turn around and say, did you know you had 10 lung nodules or 10 new pancreas cancers this week? And these stayed with you and these out-migrated. And so the ones that stayed with you were contacted as soon as they were diagnosed and were retained. And so working to show that ROI really, really fast is important. And we normally, because of those stories and the stories that that Jamie has alluded to, all that downstream follow-up and ensuring that the follow-up happens also adds up for ROI to where we've seen growth, anywhere from 5 to 20% across different healthcare systems that choose to harness and leverage AI. So good question, because it is difficult to get things approved these days for sure. So, Dr. Flora, let's transition to, in the audience, I'm working at a hospital, I'm leading the service line. Where do I start with AI? What's your recommendation? Where do I go first?
Well, I think it's probably going to start with clinicians usually. I mean, a lot of these things come from people like me that are maybe in that 2.5% early adopters, and we come to our leaders and say, we need to do a better job at this, and this is a critical need, and bring together those stakeholders that are going to be affecting the change that you need. For us, we have a new technology committee that meets. We're convening sort of an AI task force or work group to start to vet this, because you can't really have 200 different doctors coming to administrators looking for 200 solutions. That's not feasible. IT can't handle that load. The financial team will have a stroke, and then we're going to have new problems to deal with. So I think it's going to have to be vetted just like you do other technologies. And somehow we figured out how to buy a $4.5 million linear accelerator and a lead cave. Somehow we figured out how to buy 9 Da Vinci scopes. This falls into that range where you say, I almost can't afford to not do this for this population that I'm not reaching. Or how do we figure out how to better prioritize our resources so that we're able to do the things that we know other people are doing well? Following the example, people like Jamie and Inspira, I'm inspired to hear this, because those are the conversations we're having right now in our leadership meetings, is that I've suggested internally here, my whole senior leadership team, we all did a Harvard Business Review course championed by our Chief Strategic Officer and our CEO, and it was fairly expensive, and there were lots of us in the room, but it changed the way we talked about healthcare disruption. I've suggested we do the same thing, teaching people the difference between AI and machine learning and deep learning and natural language processing, so that we're at least all speaking the same language. Because as you said earlier, there is a lot of smoke and mirrors, and there are a lot of very, very good people at marketing. I think there should be evidence. I think it should be transparent. And I think you should be able to ask questions about financial ROI and get real answers, and talk to people who've been user groups and get an honest response. These were the hiccups that we had, but by and large, we did benefit, and the patients did better because of it.
Thank you for that. And Jamie, what advice would you offer to hospitals just beginning their AI journey in oncology?
I would definitely say, find a partner that can help you really across all service lines, that can extend, even beyond oncology to other areas. because, you know, when I do some of the lung cancer work on it and I'm in there looking through charts, you know, you see, you know, a lot of pulmonary patients who, oh, they're due for this, you know, there's so many opportunities. And if you can really partner with somebody, you know, that can really extend and bring your hospital together to get out of those silos, you know, that sometimes we tend to live in, you know, and it's been great for us to leverage, you know, one resource for identifying, you know, our pathology, our radiology, and, you know, just provide the care management platform that just leads right back to our EHR, you know, for everybody to come together. You know, and our partnership with ASRA, for instance, has exceeded our expectations. You know, AI is the latest trend, as we've been saying, and it's only expanding. So, you know, it's up and coming way to care for patients. So, you know, making sure our partner, you know, with it, you are to partner with a team that isn't just a vendor, you know, but becomes an extension of your team. That I think is the key, is because it is so new. There's a lot of questions. You know, you need leadership support, obviously, you know, to get all of these things, but you definitely need a partner to, you know, ensure that the system understands what we're doing and why, you know, because it is, I mean, you know, it's the way that healthcare is going, and it can bring so much to your institution. And looking at my hospital and even your hospital, Dr. Flora, we're all the same, you know, we all have the same challenges, you know, it seems whether we're big or small, you know, there's so many, you know, comparisons. So I just really don't realize how much potential. Yeah, exactly. So there's a lot of potential in these programs.
I think some of our audience members are really enjoying some of the comments that you're saying, Jamie, just around your program and how you're building it and leveraging AI. And so a couple questions from the audience, one around how is this system helping you address disparities and barriers to care?
It's giving us these patients up front. I mean, we're getting them in real time, you know, where we can connect with our navigator, we can connect with our social worker. We know, you know, ahead of time, do they need transportation? We have grant money, you know, to help with, you know, anything. I mean, it's giving us we're ahead of the game. That's how I could say it. It puts us in the lead instead of, like you had said earlier, reactive. You know, it's like, oh my gosh, this patient now has been in the system for 2 months. What do we do? We're trying to do all that stuff up front, and, you know, working with the providers and getting these results ahead of time is really helping with that. You know, the AI platform is really helping with that.
Or depending on the Dr. Floras of the world, to remember to refer because they need to arrive for an appointment tomorrow that they're probably going to miss, right? And cost the hospital a lot of money. And so I think that's true, you know, before the patient's entire world is on fire, because it is a traumatic experience hearing those words. I mean, I just truly cannot imagine having that support and starting to remove those barriers up front sets your health system apart and is a game changer for the patient and their outcomes. Absolutely. So I think that's a really good question. And then question around getting patients to screening. So how do you get patients to screening? You talked about some work that you've been doing in the community. Any words of wisdom that you would want to share about how you have had words of wisdom around getting patients to screening?
Yeah, I mean, I'm very blessed within Inspira. We have a very strong grant program, and you know, our grant manager Donald Noblet is fantastic, and his team. It's honestly getting out into the community. That's what you have to do. You have to find those little bushels of people who don't want to come out and get screened, and you know, you build that trusting relationship. You know, that's what I said. There's big university hospitals around us, but, you know, we're very unique where, you know, we can connect with those community members. You know, we have utilized mobile units. You know, if we have a mobile mammo van that we utilize with one of our partners. It's just getting out there, you know, and if it means visiting churches and all of that, you got to do the legwork. You know, you have to find them and do the legwork.
Love it. Love it. And I hear this term around AI, you know, disruptive technology. It can be really intimidating on, you know, how do I start using this? You know, we talked a little bit about where do you start, but Jamie, how easy was it to start using and to start leveraging across your service line?
Well, again, yeah, it was very important for us to leverage a partner where we didn't need to commit a ton of the IT resource hours, but still enabled us to really personalize the product. You know, this enabled quick implementation without the need to dedicate a lot of resources, and provide, improved value within a week or two of turning on, all of the different modules, and ensuring you have the staff dedicated to it. I think that's the biggest piece too. Yes, you have to prove those downstream revenue, but you have to have that leadership support up front to say, yes, we can do this. This is the end result, but we need the bodies to do it. That is the most important thing, is you need the bodies to do it. And it's manageable. I mean, even tech challenged team members can easily work with it. Our lung nodule, for instance, I think they loaded as soon as we confirmed, flipped it on, and immediately you connect with patients, and it's very easy. At least this program, ASRA, is a very easy program to use.
Thank you for that. So I know we have just a few minutes left. So let's think into the future. Dr. Flora, transitioning back to you, where do you see the role of AI and automation in oncology in the next 5 to 10-ish years?
I think even a year from now, you won't recognize medicine. So that's a very strong statement, and I'm going to stand by it. And I think that people on this call probably are feeling it. Maybe half of them are realizing it and they're terrified because their systems aren't quite ready. And they're probably championing that if they've even logged onto this call and they're looking for solutions. I'd say 2 years from now, doctors will not write notes. Provocative, right? I'd say 5 years from now, decisions doctors make in the room will be informed by a digital personal assistant who will then order the MRI or the SPEP and the serum-free light chains and put a reminder on your Outlook calendar that you need to call test results back to that patient that morning and refer the patient for massage or acupuncture or counseling or a financial counselor or a social worker or our demonstration teaching kitchen. And all of this is going to be one uniform group of people working in a seamless approach, because there is going to be a point guard behind the scenes that's managing the 20 staff members that touch each patient seamlessly.
Are there any specific emerging technologies or research that you believe could further revolutionize oncology care in the future, outside of the great and ambitious examples that you called out?
Well, we know today it's pattern recognition, right? We're probably going to see the advent of formal screening done for mammography, prostate cancer, slide reads, colonoscopy reads, lung cancer screening reads, et cetera, done by computers sitting next to oncologists or radiologists or pathologists very near term. Probably the next step will be the decision support and letting doctors have easy access to the reams of data that are coming out every night that we can't keep up with reading as specialists, to advise us that, hey, this patient had a CT scan in Tuscaloosa 4 years ago with a similar nodule, or there was an article in the Japanese Journal of Clinical Oncology last week you may not have read. Let me give you the abstract and pull this together by chatbot GPT-5. Mm-hmm. And that's where I think we're headed. It's going to make us much more efficient, much more forward thinking.
And make sure that you have the latest and greatest information at your fingertips so that the patient, regardless of what barriers they have, right? Jamie has the team that can handle that, can get the care that is recommended to them. So those are really great examples. As we wrap up, I have one last question for both of you. Jamie, we'll start with you. How do tech companies and hospitals collaborate to develop and implement AI tools effectively?
Well, I have to just say, Dr. Flora, I look forward to that future of medicine. Lots of great things to look forward to. But I think it really comes down to, again, the partners and having that customization, at your fingertips. Our experience as an example with our ASRA partners, we've met, numerous times to, speak to our team, our navigators, the people who are utilizing these, systems, and really ensuring that our needs are met, as it is more than just a program. It's not just a computer program. It's what we're using to help care for these patients, or beginning that care. So often if we need another, drop down note or added, it's never a problem. And being that AI is where so many things are heading towards, having that personalization and customization, I think is key. Because again, it's so much more than software tool. We use it to elevate the patient experience, provide that timeliness to care for patients, help lessen the burden on our providers and the staff. And again, I always go back to what we've said before. It gives us the gift of time, back with our patients, which I say technology can take it away, but AI is the direction that it's heading to give that back. And it's, again, where we belong at the patient's bedside. So I'm very, very excited to see what the future, holds for this and continuing to see it grow.
You gave an example or made a comment a few minutes ago that reminded me of this just now, where you said, it's not just the technology, right? You need the people downstream. And so you've been able to really collaborate with your hospital leadership team recently to get several navigation positions approved because you had that real-time data to say, we had this many patients diagnosed last month or the month before, or this many nodules identified that don't have navigation support or that we're losing or out migrating. And so outside of even just having the people there from the beginning, having that data to get your leadership team on board, as much on board as Dr. Flores is, which I know they are, Jamie, but to get positions approved and to get that support there has been really impactful too, and an interesting collaboration that I've seen over the last several weeks.
Oh yeah, absolutely. And because the metrics are there, the data is there. You can't just say, hey, I need 3 bodies. Why? Oh, because we've had a lot of tests, and you go through each chart to figure out exactly what, but here, you can say that from the labs, from X-ray, from PET scan, everything is just at your fingertips to say, here you go. And you can't deny it, it's in black and white. So great point.
So Dr. Flora, with 2 whole minutes left, any last remarks or anything that you want to share around the future or where it's headed that you want to add to the conversation?
I guess I would just close by being encouraged. This is a gigantic paradigm shift, and it's going to be hard to wrap your minds around, and everyone's going to have to read, and you're going to have to take a deep breath. I felt that way when I lost the buttons on my cell phone because I was a huge BlackBerry fan. I think probably they felt that way when Model Ts rolled off the line in Detroit for Henry Ford and all the buggy drivers suddenly found themselves out of work. It's here. It's unavoidable. It's teaching itself more than we've learned in the last 10 years while we were on this call. And so you're not going to find another world that is expanding as quickly as artificial intelligence, because for the first time in human history, it's training itself. And that's the whole point of deep learning. This black box is going to either work for us or against us. I'd rather be at the lead. I'd rather be leading the discussions. The whole idea behind starting this journal, and every day I'm sharing on LinkedIn something that's designed to say, let's drive this conversation for that last mile to get it in front of the patients and the clinicians who need it. And to do that, we've got to do it legibly. We've got to do it in a digestible fashion in forums like this. That's why I agreed to do this, because I believe the message is as important as the product right now, which is fear not, this stuff can be used for good.
Right. Well, thank you, Jamie and Dr. Flora. Thank you to everyone in the audience. There were a couple questions that we did not get to, but we will follow up with you individually to make sure you have the information you need. So appreciate the time, and we hope everyone has a great rest of their afternoon.
Thank you to our speakers and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, October 8th through 11th for Health 2023.